Welcome to Team Gut Girls, the podcast for anyone who's ever unbuttoned their jeans at 10 a.m., mapped out every public washroom in a 10-kilometer radius, or wondered why one bite of food can ruin an entire day. We talk about bloating, constipation, diarrhea, reflux, nausea, abdominal pain, histamine chaos, and all the quiet gut symptoms you're told to just live with. Join naturopathic doctors Dr. Whitney Baxter, Dr. Christina Carew, and Dr. Dominique Vanier. Your gut is talking, and we're here to help you translate. You're with Team Gut Girls now. Let's dig in.
And before we dive in, just a quick note. This podcast is for educational and informational purposes only. It's not meant for medical advice and doesn't replace working with your own healthcare provider. We're sharing general information, not diagnosing or treating anyone. Please always talk with your physician or licensed healthcare practitioner prior to making changes to your health, medications, or supplements.
Awesome. So, welcome back, listeners. Today, we're talking about a motility concern that can cause bloating, but in the upper part of the body versus the lower part of the body, which is a lot of things that we've talked about so far. And so let me set the stage for you. You're eating a normal meal, nothing unusual. It's not a buffet. It's not all you can eat. And very shortly after, you still feel bloated, uncomfortable, nauseous, and you feel like your stomach kind of hit a pause button, like there's a heaviness or sensation in the stomach. And so this could be one indicator that one of the considerations for your bloating might be something called gastroparesis. And gastroparesis is a motility issue, and it's often missed or underdiagnosed. So the actual data is about 1 in 10 people with it have been diagnosed correctly with it. And it's often sort of brushed off as reflux or anxiety, because it's not really well understood. And we know that it affects only about 1 to 3% of the population currently. However, there's a lot of data that suggests that this is a growing area of concern because more people have diabetes than have had in the past, and this can be a complication of diabetes. But in addition to that, we see a lot of the GLP medications and the GIP medications also have this as a bit of a side effect. And so I think we're going to see more of this more often. And so if any of this kind of hits home, it might be worth investigating a little bit more. So quick way to think about gastroparesis is that it's a paralysis or a motility paralysis in the stomach. And so if we're thinking about the way that our food gets digested, it should be about 20 to 25 minutes from the time that you eat something that enters into the stomach. And then once it's in the stomach, it should be there for about, 20 minutes to an hour on average. Sometimes medications that people are taking, PPIs, opioid medications, GLP medications, delay the onset of the emptying of the stomach. And so that time may range between 1 and 4 hours. Gastroparesis is considered anytime the stomach empties less than 60% or more than 60% of the stomach contents should be left within 2 hours. And if it is a longer period, 4 hours, there should only be maybe 10% of the stomach contents left. So if there's more than that, it's considered a delay in the emptying, or what's this condition called gastroparesis. And so the traditional medical system is often educated on this as a step in advanced diabetes. And so 25% of the cases are generally found currently in people that have diabetes as a complication of diabetes. And so this is one of the myths that sort of exists in the system, is that, only people that have diabetes can have this, and that people can only have it all the time. And so what we often see in actual clinical practice is that this might be a condition where people are having it some of the time, or with certain times of cycle, like hormonal, or certain types of times when there's more stress in their lives. So it's a multi-layer type condition, and it's not just related to diabetes. In fact, in my clinical practice, I deal with a lot of patients that have complex chronic illness. They have multiple things on top of each other. and they're often struggling because every specialist sort of has a different take on it. And so a lot of the work that I do is, how do we put these all together? And there's a whole set of clinical reasons that we could also see this. So people have mycotoxin or mold toxicity. People have Lyme or tick-borne illnesses. Because in these cases, these types of infections, they create lots of inflammation, but also create autonomic nervous system dysregulation. And so your stomach is something you should never feel. You should never feel that it's something is happening in it or not happening in it. And if you are feeling that, it means like your nervous system is wired in a way where you're starting to notice it because things aren't moving as well as they should. It should be something that just happens without you thinking about it. You don't have to be like, oh, now I have to think about my stomach needs to turn on. Just happen. And so other types of conditions we can see this in are things like Ehlers-Danlos, so hyperflexibility of the connective tissue, in particular like the veins and in the arteries. We see it often in people who have POTS, so dysautonomia, meaning that the body is having dysregulation of blood pressure. And so that also creates a change in how our nervous system functions, but how we get blood in different parts of our body. We'll see it also post-viral illness. So we're seeing people that have just this ton of inflammation that's going on. And so that actually creates a disruption in the signaling. And so we do have an episode where we talk about disorders of the gut-brain interaction, and this may be one that's considered within that pool because there is some belief that there is a signaling issue from the brain to the gut, in this case in the stomach versus the intestines, where the signaling isn't happening quite as often as it should. So anything that affects the nervous system can affect the signaling. And so when we think about things along these lines, we need to also think that, all this inflammation or this anxiety or this low hormone production that I'm having may actually be affecting my body in other ways. And so it's not just a digestion issue, it's a chronic issue. Okay. That's sort of like the beginning. Okay, so how do you actually feel? I would say the most common symptoms that people show up as is like having chronic bloating, early fullness, so just feeling like they can't eat very much or they don't eat very much at all and then they feel quite full. And then the other being reflux that doesn't respond to medication. So reflux just meaning like it doesn't feel like there's space for the food to come down. Sometimes that results in nausea. Sometimes it results in nausea with vomiting. And certainly any kind of upper abdominal pain. So we're thinking about things that are like above the belly button, sort of by the rib cage, and this like kind of full sensation. Questions so far?
Well, it's interesting because, so Christina and I both spoke at a conference yesterday in Toronto, and Whitney, we missed you because you were all the way in BC, but what we talked about was Christina did a great presentation on gastroparesis, but we can see an overlap with gastroparesis and, like we talked about, disorders of gut-brain interaction, specifically like functional dyspepsia, where they can look exactly the same, because functional dyspepsia being like burning, belching, early satiety, fullness, nausea without vomiting. So gastroparesis, it doesn't always, it can look like other things as well.
For sure. And you can have more than one thing at a time.
Yes.
And so you can have overlapping conditions that share some commonality, and maybe some things are different slightly, which is why it becomes super confusing, even when you're GPTing all your symptoms, because it's starting to give you the spectrum of things that might be happening. And so I think part of the reason is that our go-tos in this space in the body usually are things like proton pump inhibitors, H2RA, so things like Pepcid or famotidine. We're really good at treating acid, but we're really bad at kind of thinking about things that are beyond that. So H. pylori, gastroparesis, any kind of lower esophageal sphincter that's not operating properly, hiatal hernia. And so there are lots of conditions that can cause this type of symptomatic kind of sensation in people. It's just that it's not always top of mind because they're more rare, potentially, or maybe just underdiagnosed. And so not rare at all, but people just aren't thinking of them.
Or it gets lost in like the treatment algorithm too, because often patients will come in and, like you said, we're good at treating acids, or proton pump inhibitor is like the first step in the trial. And then if that doesn't work, we're maybe not always thinking about gastroparesis, like these other functional things that could be happening. We're kind of thinking more of like the reflux hypersensitivity or the disorders of gut-brain action interaction side of that spectrum.
And like the testing for this isn't fabulous. So this is another part of the problem, is that there are hospitals that can do manometry type testing or scintigraphy testing. And generally what happens is the patient gets a radio labeled egg salad sandwich, and they take imaging as the sandwich transitions through the intestinal system to see like how long is something there. But the challenge is like a true gastroparesis is more than 4 hours, having more than 10% of the stomach contents. But someone can have it for 3 hours before it empties and still have this delay and this uncomfortable sensation, but not be diagnosed as having this true, claimable position. And this is part of the issue, is just that, how long is long? And so if you're having symptoms, even if it's perhaps all the way to this kind of end extreme, there are things that can be done. You don't have to wait until it's worse to get better. And I think that's hopefully what we're communicating in the podcast series for people, is that there are all kinds of things on a spectrum that don't involve a surgery or aggressive medication that still can be fixed. Okay, so let's think about sort of like areas that we think about when we think in this area and what some of the misconceptions are. So what do you guys think some of the like sort of areas where people are like, how do I know if this is it or not?
Okay, so maybe the gastroparesis is a stomach motility problem and not a digestion problem.
Mm-hmm. Yeah, so it is like how it's like not a matter of what you're eating. And so I would say, as a clinician, we often see people come in and they say, I can barely eat anything, or I can only have something that's liquid. And so some of that in their mind is that the food they're trying to eat chicken. And it's the chicken that is causing the issue, not that the structure or the function of the digestive system is what's causing the issue. And so it's not about taking more foods out in this instance that's going to make anything feel better. It's, in fact, sometimes smaller meals that make a difference. Or I have a patient that like literally blends potatoes, chicken, and carrots together in this very sludgy type of drink. And that is literally how he gets his food in, to be able to get protein and things like potassium, which are in potato, and like some of the nutrients that are in carrots. And that is the way he gets his food in, because he has such a long delay. So he's like, well, the most of the work that the stomach does has actually nothing to do with absorption. It has everything to do with making the meal more palatable for the intestines to be able to absorb things out of it. So if we can make it less dense and less hard to break down, we're actually kind of giving the stomach a little bit of a break. And hopefully that helps with the improvement in the emptying time.
Kind of like going back to the simple lifestyle tips and tricks to help your bloating is to chew. One research paper said 40 times, but as much as you can to really turn it into more of that mush, because then that's, saliva has some, and there's some digestive enzymes starting in your mouth. So when it gets to the stomach, it doesn't have to do as much work to get it into that.
So that would just significantly affect somebody's quality of life, right? If it gets to the point where they have to make their food into like a sludge type of texture. Yeah.
As a clinician, one of the screening tools that we suggest that the healthcare providers that are seeing patients that are experiencing this too is to like do a lot of anxiety and depression screening. It's like your life is really dramatically changed. And lots of times the medical system is reliant on a couple of medications to make a difference. And if that doesn't help, people are sort of left with this idea that this is how they're going to feel forever. And there are lots of things that fall outside of the medical treatment system that can be helpful. So to know that there's things beyond pharmaceuticals that can be helpful. And this is also a growing industry. And so there's like 12 or 13 different pharmaceutical medications currently in clinical testing to try to see if there's other ways that we can, as well as tools, like things like, almost like pacemakers for the stomach to help to trigger with emptying. And so this translates to bloating. So bacteria found it in bloating because like it feels like everything is stuck for a long time. And just because it's stuck in the stomach doesn't actually mean that once it leaves that place that it moves easier in the rest of the intestine. So we notice it in the stomach, and this idea of like just feeling like food is sitting and stuck and heavy and maybe causing some nausea, but then it also is going to be delayed throughout the rest of the system. And so it's very common that this patient population has a lot of constipation, has a lot of like additional like abdominal bloating, because it's also like everything is fermenting as it sits there for so long in a space where we don't expect it to ferment as much as it is. So we're getting.
So are people noticing like higher, more distension bloating because everything's just stuck and building in the upper?
Yeah. Things that people will say is just like, I can't eat anything, or I can't eat anything until a certain time of day. Like it feels like, or like, so at the conference, I told that I have two patients in particular around the eating piece that's really distinct for them. So one can only eat an egg on half a piece of English muffin in the morning as long as it's before 8 a.m. And then after 8 a.m., she cannot eat anything. Like she's not able to like digest and move anything at all. Before 8 a.m., no problem. She can eat that. That feels like a safe food for her. It's easy for her to digest. So she's still getting nutrition from it. So she's losing a tremendous amount of weight, which is part of the problem. But she could eat that. I have another guy who's the opposite. He can actually only eat at 8 o'clock at night. And so he finds that like if he tries to eat anything during the day, he just feels really unwell and sick. But for whatever reason, by the time night falls, he's more relaxed, food is easier, and he doesn't have to blend his food. He eats like generally a regular meal. It's just a. And so some of this is like that gut brain piece, right? Like how is the body getting the signal? What else is happening? What's the role of stress and anxiety around eating? Things that people have tried. So it's not that there isn't also a component where the body isn't sending the signal forward, but it's a component where the body isn't ready to send that signal because there are all these other confounding factors.
Yeah, it's really about when they feel most safe to have that meal, and therefore the nervous system agrees a little bit more and supports digestion. Yeah.
Yeah, so we see like upstream bloating, like reflux, nausea, upper abdominal bloating. So people will often say like this starts under the breast. And then we may also see the lower bloating, so like more gas, distension, because everything's quite delayed. This is also sometimes a person like vomited 8 hours after I ate and the food still came out.
Yes.
We see some of those people in clinic. Or they'll say like, I bowel movement and I saw the food that I ate 2 days ago. Like they're not getting that breakdown. So it's not just about what you're eating, but are you even getting nourishment from that food? So one of the questions actually that one of the people in the audience asked was around sort of this, connection between this and the vagus nerve and the nervous system. And could things like care from like an osteopath, would that be something that could be helpful? And so we know that the vagus nerve is really the innervation piece. It's a coordination of a lot of the systems in our body. And typically we don't also have to be like, oh, I need to turn my vagus nerve on. it should be just kind of functioning. And so it's an automatic function, but we know that those automatic functions get derailed at times. And I would say a common thing that I see in a lot of these patients is because they feel anxious, not just because of not being able to eat or being worried about eating and then vomiting. They also are feeling very anxious because they don't have a lot of nutrients. And so when we are more nervous or we have feel more anxiety, we tend to breathe more from the upper part of the body. And so our diaphragm actually doesn't get that full range of movement. And so if we think about our diaphragm in relationship to the stomach, esophagus like runs through the diaphragm, which is then the stomach's on one side, and the diaphragm sort of becomes this like umbrella, one of those big balloons over top of it. I think about like the hot air balloon kind of material. And so the esophagus is kind of running up and down. But if the diaphragm is too tight, then we're also not getting the flexibility of movement, which is also going to affect our motility, but also make us feel like things are even more stiff than they are because we're actually not getting movement inside our abdominal cavity. And so there are things like manual therapists that may be very helpful in helping people to move things forward just from a relaxation of all the other things that are discoordinated when something doesn't feel good.
It's interesting because you see this overlap too with constipation, right? And sometimes, we're going to see multiple things, like you said, in one patient where they may be more likely to have constipation. And then we know that the diaphragmatic breathing, the diaphragm movement, and even the pelvic floor support is really important for those individuals. So yeah, it's really not, it's not black and white, right? Like we can't always tease apart all these kind of different conditions.
And different things are going to work for different people. So if the paralysis is due to a medication, we might see that, as the day wears on, the medication wears off, then things change, right? Or if it's due to a stress trauma or a viral illness, we may see that changes based on how the immune system is operating or what's going on in the environment. So it's one of these things where it's like, kind of maybe affects you in different ways at different times. And as a person who's experienced it, you're trying to look for all these clues because you're like, well, it must be because I ate strawberries and it was 2:00, right? And so you're trying to figure out what's the pattern. And so it becomes really challenging because in that you just start to vilify things that you're like, well, I can't eat this meal, or I can't eat standing up, or I can't eat at this person's house. My grandma actually, I think that she actually had some level of gastroparesis because she would tell me that she couldn't eat chicken at a restaurant because it would feel like it got stuck. But she'd eat chicken at food. And it was like really interesting. And I think that it was like the anxiety of being in a restaurant was like part of that. She's older. She's on a lot of stomach acid. She probably had hiatal hernia. Like she had all these other contributors. But she would always be like, I vomit up the chicken if I eat at a restaurant. It was like, but then I was like, also, did she teach herself? Like it happened one time and then she consistently remembered that. She also liked to not watch TV with the sound on. And so she'd be like, that yogurt makes people run to the bathroom. And I was like, actually, they're running to the gym. And I was like, why would they put that on a commercial? She's like, I don't know. So grandmas are fun. Okay. So we have some early satiety, we have nausea and food aversion. It's a little bit different from like some of the bloating we've talked about earlier. So a FODMAPs type bloating where we're getting like food that's creating more overgrowth, so maybe SIBO or other things, that usually would be more fast, only because in a gastroparesis situation, the stomach still has the food in it, where in a FODMAP situation, it's getting to the small intestine. That might be kind of a little bit of a different history.
And with that, it is more reproducible. Like you can do a low FODMAP diet and see some patterns in the foods that you're eating, whereas gastroparesis, not necessarily with the foods, more that timing of the 1 to 4 hours after your meal.
I will say there's a caveat to it, because if it actually is functional dyspepsia, then we will probably see an improvement with FODMAP. And the dyspepsia can look just like gastroparesis. And this is where it's messy.
Yes. Yeah.
100%. Well, and like the histamine piece is also a bit of a crossover because we know that histamine aggravates or inflames the system, which we can see in dyspepsia. We could also see gastroparesis, and we can also see just with a histamine issue. And so histamine might be bothering someone. That's why sometimes when someone's given like a lamonidine or a Pepcid, they suddenly feel like things are a little bit better because the stomach is the highest histamine 2 receptors. But it could also go the opposite, that they feel it's much worse because now we're taking another layer of that digestive piece out of it, which is where everything is already blocked in. So it's not easy. Not easy at all, and not super easily treatable. So we can send people for that motility patterning and at least even just get the data to look at it ourselves to say, okay, well, is there a delay? I know where I practice that like the time to wait for that test is between 8 and 10 months. Like that's a long time for people because there's not a lot of places currently that are doing. So it might be different wherever you are, listeners, but also just to keep in mind that some of these testing options are very rare, and so they do have longer lists waiting for people. Okay, so I would say, what can we tell people in terms of things that might be able to help them as a way to kind of see if could they make some headway while they're waiting for testing or to find a practitioner that knows a bit about this to help. And I would say there are some things in the research that might be useful, which is not having a lot of restrictions, because we know that restrictions, as we've talked about in other podcasts, have definitely worsened motility because we're now not getting all the nutrients necessarily that would help us to make motors move. Certainly things like that. We know that in a lot of the types of symptoms that we see, that having routine and pattern is actually really important to people. And so having the body know that this time of day, no different than babies, this is the time of day you're getting your nap. This is the time of day that you're eating. This is the time of day that we go to bed. So if we get out of pattern where we're skipping meals or we're having long periods of time where we're not even trying to eat food, we get out of this rhythm that our body now feels like more deprived in deprivation. So certainly that can be a piece. It might be finding some really interesting ways to make food taste better or more accessible. So it might be smaller meals. It might be more blended meals. It might be having like really concentrated protein drinks or having really dilute protein drinks. Having things that are more small food particles. Like these are types of things in the research that seem to help. Because eating less is unfortunately just kind of just drives the system farther into a state where it can't find its way. So how, what would this look like if you're getting treated? And I think that this is always helpful for patients just to understand sort of like what happens. And so I would say there's kind of, I think about it as steps. So step 1 is like making sure that any of the medications that you're taking are not causing this issue. Making sure that all of the symptoms that you're experiencing are tracked so that you can see if intervention are helping, even if that means that you can't eat a big meal all the time. You were able to eat it 3 times this week, right? There's some improvement. Making sure that mental health and eating disorders are looked at, because certainly our mental well-being affects our physical well-being. And looking at micronutrients. So because the diet is very limited for many of these people, certainly things like iron, B12, vitamin D, zinc, calcium, fat-soluble vitamins, like all those can become very low. And so in some cases, as much as withholding some of that seems like it feels better, in withholding it, we actually end up in a situation where we make things worse. It's sort of like if we think about it as relationships. someone bugs you, your husband bugs you because he puts his socks wherever, whenever something basic, right? And then over time, you're like, oh, and then this, and then there's this, and then there's this, and then you have the massive blowout. And then sometimes those are repairable, and sometimes they're not repairable based on, how long had it taken for you to distance all the things that have been building. And so when we think about conditions and the more things that we do to feel better, we also have to learn how to undo all of those things in order to be able to get back to the healthy state we were in.
It's challenging, right? Because when we take out foods, or at least in so many discussions with patients taking out foods, it's kind of like their first attempt at control and supporting themselves, right? And it's really easy to go down that rabbit hole of like, oh, it's this food, now it's this food, and I'm sensitive to this food. And the thought being, okay, I just need to take it out and things will improve. But we even know like lower down in the digestive tract, when we remove food for long periods of time, we can affect the microbial community there. So then we can start seeing like an upper and lower GI issue.
Yeah, one thing causes another domino falls down.
Mm-hmm.
I would say,
and it goes into that loop too. We'll talk about this, I'm sure, in one of our episodes, but there's like a whole separate eating behaviors category called avoidant restricted food, ARFID, food disorder, where it's a fear of the food, not of the weight. And it just becomes, like Dominique said, a piece of control, and maybe you feel better some days. Okay, I got it. I got my system. I can go out to eat. I can take a breath and live my life. But we get into these patterns without noticing it too. And you don't even notice the foods that you're sticking with might be low in certain nutrients. So it is kind of good to take a step back and do the screening and track it a little bit.
Mm-hmm. Mm-hmm. And I would say part of the reason that the food becomes a big component of this is that the nausea vomiting sensation is fairly significant for people.
Yeah.
And anyone that may have tried a GLP-1 may have also felt that. That's actually one of the common side effects of it, because of the delay the GLP-1 creates in the intestinal tract. It actually purposely causes some motility issues so that people feel full longer. And in doing that, you feel sometimes more nauseous. But we have lots of antiemetics, so anti-nausea medications. We use them often. Pregnant women, we can use them in situations where people have chronic nausea and vomiting. So this is an area you definitely can talk to your medical practitioners about. They exist in pharmaceutical, and they also exist in things like acupuncture, acupressure, and vitamins that may help. And so all of those might be things to consider. And depending on where you live, cannabis may or may not be illegal. And for some people, cannabis has an impact on lowering nausea. We see it sometimes in cancer patients that are experiencing nausea from treatments. We also can see the other way, that cannabis hyperemesis, meaning that cannabis can induce this sort of vomiting syndrome that happens every morning. It's just vomiting syndrome. And so being cautious, like how much you're using, and is it helping or not helping? I would say that would be one area. I would say the delayed emptying and early satiety, so meaning that people just aren't eating very much, is another area. And so we have a whole classification of medications that are called prokinetics. They help with motility and movement. There are varying degrees of hazards behind them or risks behind them. So certainly talking with a professional about that and by internet would be super important. And if you do buy them on the internet, you're telling someone about it so that we can make sure that you're being tracked appropriately, because I have a patient that was left on one of these medications for more than, since she's 20 and she's almost 80. And one of the side effects of one of the medications is that you get QT prolongation. So you get changes in the heart rhythm. And she actually came to me because she had changes in heart rhythm. And I was like, holy smokes, you've been on this medication for 50 years, which causes this. And so the medication was causing the issue, which would layered another medication on top of that, on another medication on top of that. I was like, oh, this is just a side effect of this medication. You probably shouldn't be. And so I think sometimes it's like being mindful of how long you're using these tools for. And as long as they're helping, that's great. But but maybe they're not doing what they once did, and medication always for life. And so being able to talk to your pharmacist or talk to your professionals that are in your life about those is really important.
Yeah, certainly. Yeah, reevaluating at the appropriate times and then really having like targeted outcomes. Like, is this helping? What's it supposed to be helping with? Can we decrease the dose? Is there still an effective response if we decrease the dose or switch the medication or what have you, right?
Is there a safer drug now that has better effectiveness at a lower dose, less side effects?
Yeah.
It's always nice to have fresh eyes on these things that you think are so standardized. Like, oh, this is just my medication list. Like your doctor knows, but to have fresh eyes on it and really just sift through, because life changes, gut health changes all the time.
PPIs is a great example of that, right? Like, how many times do we see people on PPIs where they're supposed to stop somewhere between 8 weeks to 6 months, and then they've been on it for a decade?
Yeah. And then, PPIs are one of the causes potentially of gastroparesis. And so, like, full circle. I'd say this second kind of category in this sort of early satiety, but also some of that hypersensitivity or feeling that we get, it would be neuromodulators, which Dominique, you did lots about that recently. And so neuromodulators are just medications that can help our brain to rework some of the wiring. They sometimes are also considered medications that fall into the antidepressant or anti-anxiety category, but also pain relief category. And so sometimes if your practitioner suggests this to you and you're familiar with it for one reason, it's good to ask them, like, why are we using this? What do you expect to happen? How else can this work? Because they may be thinking of it in many different ways, but haven't actually communicated that to you. So it isn't all in your head, but there are some pieces that, if regulated better, may actually help.
Yeah, neuromodulators are pretty cool. Like I would say like they have a lot of attention now in the research, because previously, especially like the tricyclic antidepressants, at certain doses, they've been used for more like the antidepressant, anti-anxiety category. And now at lower doses, they're seen to actually have a big impact on some gut conditions. Yeah, like the hypersensitivity part, like you spoke about.
Yeah, we see other types of things outside of the pharmaceutical world, right? Like hypnotherapy and mindfulness and CBT and breathing and osteopathy. Acupuncture actually has some really good evidence for helping with getting emptying and movement of the system. So TCM targeted medicine may actually have other pieces within that, is the body hot or cold in terms of like how things are moving. And then there's lots of botanicals that work in this area. So there are herbs. So if medications aren't working or aren't working well enough, or combining a medication with a herb makes you be able to keep it at a lower dose or for a shorter period of time, these are all ones that could be considered. And then if things aren't getting better, you should definitely talk to your practitioner about, getting more help. So there are enteral nutrition, so getting like feeding tubes that might be helpful, even for a short period of time, just to get your strength back up. Having integrated practitioners, so naturopaths, with your GI doc, with your dietitian, with your psychologist, and monitoring your symptoms. So things like weight are big ones, nutrition is a big one, participating in life is a big one, and making sure that things are helping that you're doing, and you're not just creating more stress by having a longer list of things that you need to do every day in order to feel like you can get moving or get things moving. So how would you guys want your patients to come in and talk to you about this? So what are ways that they could bring up some of the suggestions in terms of how would you start a conversation, or how would you want someone to start a conversation about this?
I think a really important point we talked about is kind of taking the blame or the villain away from our foods and just starting to notice your bloating pattern. So yeah, you ate, but then when did it start? How did it show up? And what does it feel like? So getting really detailed about the timing of your bloating, when does that fullness happening? What are the sensations you're feeling? Even if it's with small meals. And then you could say something like, I'm wondering if gut motility or delayed stomach emptying could be contributing. Could we explore that to your practitioner?
Yeah. And then certainly like what tests can we do to better differentiate whether this is a stomach issue or another potential issue.
Yeah. And I think that gastric, like the words gastric emptying are helpful because the practitioner that you're seeing may not be thinking about that. And so once you suggest the word, that they're like, oh, wait a second, maybe that is a part of it. I just don't think it's high on our radar of potential diagnoses, but I think it should be. And hopefully podcasts like this and people asking their doctors more will help them to get some more of this information out. And for this episode, I actually made uploading and motility pattern checklist that people can download. So you're going to go to the show notes, which is on our website, which is team.girls.com. You're going to go to this episode, and underneath it, you can see both the transcript, but you can also see some checklists. And taking that checklist with you to the doctor's office can be really helpful. It's something you can leave behind and really tell them like what are the things that you're experiencing, so that it's really clear for them. Because even if they're going to write you a referral for some of these tasks, they need to have a real clear understanding of like what is the symptom that you're experiencing it. Because writing it on the referral can make that referral happen faster. And so just exploring gastric motility may not be as effective as, say, exploring gastric motility because of rapid weight loss, because of chronic nausea and vomiting. So the more descriptive we can get in the information that's passed from specialist to specialist may actually help improve your case.
That's really helpful. Christina, thank you for putting that together. I think what's also important is gastroparesis can occur in the absence of diabetes, right? So practitioners need to know that if your patient does not have diabetes, it doesn't mean that they don't have gastroparesis.
Yeah, it's just like one of the reasons why people get it. In fact, it's still only 25%, which is a large percentage, but there's still 75% of people that are getting it. They're not necessarily, it's not a first-line consideration because it's thought to be, one of these diseases that happens because of diabetes. So a huge part, for sure. Any other last thoughts?
I think we covered a lot of pillars today. But I think, reiterating, Whitney, your point, which is like sometimes getting a second set of eyes on this because if somebody's been experiencing these issues for so long and they've been down the rabbit hole of cutting out all the foods and maybe tried certain medications and their quality of life is so significantly affected still, or they're just not seeing, they're not seeing their symptoms improve to the way that they would expect, is you need somebody else to help you in your corner.
Especially with this one, because it could be as straightforward as a medication side effect, right? Or you could be an individual with something more complex, like an autonomic dysfunction or chronic viral illness, or even the connective tissue disorders where you have all of these random symptoms and no one's really been able to figure it out. And because you're seeing a lot of specialists, and this is one key piece that affects like a lot of hours of our days and our energy if you can't eat properly. So yeah, I think it was really helpful just to re-listen to how to talk to your practitioner and be really specific with the terminology and timing and what you're feeling.
And if your practitioner says, I don't know anything about it, just say, can you send me to someone that you think might? Or you might even come in with that information because you've done some of your own research or someone has suggested it, whether that's on Reddit or ChatGPT or in a Facebook group. Try not to take all of the information at face value, but recommendations of practitioners who people had good experiences with are great people to bring in and say, I've heard that this doctor has helped someone else with this. Maybe you could send me. That's honestly how we get sort of some of the best and most informed practitioner care is knowing who the person is that we're sending them to that has a specialty or an interest in this area. Well, thanks everyone for joining. So the show notes will be loaded up. You can follow along, definitely pull things out. We are continuing to do this series because we believe that gut health really does impact everything in your life, and the better that feels in your body, the better you feel. And so remember that better gut health changes everything, and we'll see you again next week. Thank you for joining Team Gut Girls. Like, follow, subscribe, and share a podcast with friends you think will want to know more about their gut. You can also visit us at teamgutgirls.com for show transcripts and more information, because better gut health changes everything. See you next time.